So, welcome to what is now the second annual general meeting of Southern Derbyshire Clinical Commissioning Group, and thank you all for coming. I can see in the audience we've got a mixture of our GP members, various members of the public and some of the organisations that we work with, so welcome to all of you. What we're here for tonight is in order to share with you our and present to you our annual report for the CCG for the years 2014 to 2015. Within that report there is a lot of information about the work we do and a presentation of our accounts for the year. The purpose of this meeting is to share the 14-15 activity with you, and clearly the presentations that we give tonight are really a taster of the things that we have done. So if you look at the report, you'll see there's an awful lot more in there and an awful lot more detail.
We run a number of work streams in urgent care. We have 4 urgent care work streams, and we use those to develop clear plans that help us improve the way that we deliver our services wherever our populations access them. And throughout the funding of 2014-15, as well as the contractual ways that we fund our organisations, we also receive some extra funding to support the delivery of support for our patients and improving the way that services are delivered over the difficult period of winter. And last year, the way that we addressed those, the developments was through our system transformation group and through our urgent care board, and actually making sure that we supported many different organisations with funding. And I think that the areas that we supported last year were quite diverse, and they included transport to allow our patients to access district nursing a lot quicker than before, supporting our Stay Warm and Healthy campaigns within our local authority, as well as continued funding for our dementia housing partnership work with the local authority to support our homeless population. And in addition to that, we also fund innovative pathways within our acute providers such as Derby Hospitals, our mental health partners, and our community hospitals.
Over time, the investment in general practice and the recruitment to general practice has been eroded. So most GPs in this room and most GPs who will talk about the pressure on general practice. Some of the ways out of that difficulty is around practices working together and organising their work in a way. And the general practice alignment we're talking about there, the place we've started is aligning general practices with care homes, which has a number of benefits. Firstly, it means you've got a smaller number of relationships to manage. So as a GP practice, you can build a relationship with a care home that you've aligned to. You can start to understand each other, and then you can start to build ways of working which allow for sort of mutual engagement and a much more streamlined working and much more mutual support, really. And one of the sort of side effects of doing that is GPs practices in an area have sat down and talked to each other and said, okay, who's having which care home? How are we gonna arrange this? Those sorts of conversations have been really instrumental in some of the what we're trying to do for next year, which I'll come on to in a second.
And in a nutshell, that project is to provide a pathway for health and social care professionals into voluntary sector services that can support patients, help them stay in their own homes, live independently in their community, and basically contribute to keeping them out of hospital, keeping them out of residential care, and as I say, keeping them living independently. The reason we started this project is because the voluntary sector is huge. You know, you've got, on the one hand, you've got massive organisations that are multinational, national organisations, right down to very small self-help groups, 3 people meeting in someone's front room, and that is the spectrum of the voluntary sector, and it's huge. And in Derbyshire, there are, on Derbyshire Directory alone, which is a directory of voluntary services, there are around about 5,000 groups. And that really is just the tip of the iceberg. There are lots of things that go on in villages, in small communities that, you know, that help support people and help keep them living independently. And really, you know, what we want to do is why would health and social care professionals know about that? That's not their jobs to know about what those services out there are, those activities within those small groups. But actually they can make a massive contribution to keeping people living independently, improving their quality of life and improving their health and general well-being.
Within cancer, we've also seen significant improvements. There are still some small targets in some specialties that are proving more difficult to deliver, but we work collectively with the Trust to look at where we need to invest and also where we need to redesign care to improve services. Very quickly, in terms of next year, we've got a joint transformation programme working with the Trust, and it's a lot more of the same. It's constantly trying to look at where we can standardise care, where is the really good care that we then need to make sure everybody gets access to, because sometimes there are pockets and it's not always universal. Where are there steps and duplication that patients find really irritating and it is not good use of resources, and we constantly look at individual pathways, individual specialties to try and find that and take that duplication out. Looking at opportunities around virtual clinics and one-stop clinics, different use of technology to make sure that the service is as effective as possible. There's some things that don't need to be in a hospital setting, or if they're in the hospital, they can be in a less intensive setting. So things that are in inpatients now that can be done as day cases. They're day cases, they might be able to be delivered in an outpatient setting or outside of the community. We also have to look at the overall cost effectiveness of that and ensure that clinical competences are maintained if services are delivered in a different place by different personnel. But we're constantly looking at those. And some of the things we're working on this year is around injections, the joint injections, which a variety of staff do, and we're looking at where they could best be delivered. And also diagnostics. There's lots of technology in terms of mobile diagnostics that we're testing out and looking at how that would change the services that we buy and the Trust offer. And lots more. It's a bit of a theme tonight about effectively working together. So we can only do this if we all work together. And we've set up a clinical provider partnership for musculoskeletal services where we've got consultants, GPs, physiotherapists from the hospital and the community sitting down with us to look at where there need to be changes, what could be improved, because it's those clinicians that can best advise about what needs to be done, and we can approach the problems together and in a different way. We're looking at building on that, the Consultant Connect. How do we make sure the specialist time can support GPs, which doesn't have to be sending a patient in for a referral. The traditional way to get advice is to send the patient to the hospital, and we want to look at where we could do that differently. And constantly working together to redesign services. We've got good plan care services, they deliver really well, but we need to constantly review them to make sure they're as effective as possible and as cost effective as possible. And that's what we're doing for the current year.
But again, we continue to learn from this, and we will continue to work with our member practices with regards to that. That brings me to the second point which Ian raised about general practice working together. I mean, general practice is a very traditional model. We are trying to change the way GPs and GP practices approach working with neighbouring practices and colleagues. We've held a number of events already amongst various localities where we've encouraged practices to talk and try and find ways of working in groups, so we will continue to do that. I'm pleased to say that we're seeing some the fruits of some of that success now coming out. But again, it's a lot of work involved in that, and we will continue to try and work with all 56 practices on that. With regards to strategic planning, we are in the process of developing an estate strategy, which we hope to have ready by December. We're also working on a wider primary care strategy, and that's something we will be going out to localities and practices to discuss further as we have a clearer direction on that. We will continue to look at IT developments. We have I've already mentioned about the websites. We're also looking at sort of ways of consulting which involve a non-face-to-face contact with patients, so things like Skype. We will also look at IT as a part of the general wider requirement for healthcare services, and so sharing of notes, patient access to medical records will form part of that. And as mentioned earlier from Ian, where we actually sort of will have the wider community teams, we want general practice to be really a key part of that, and therefore we will continue to work with practices to encourage involvement in that. As I mentioned starting off, it is a very, very difficult time for general practice, but the CCG remains committed to having a very resilient, sustainable, high-quality general practice service right at the heart of all the community teams that we are working with, and that's something we'll endeavour to continue to do well past 2015.
You'll recognise that Bristol, the Francis, the Winterbourne, the Morecambe Bay, sadly, for all the very wrong reasons. We could add Bristol in there, we could add Shipton in there, we could add Savile in there. You know, our aim is to deliver good quality healthcare. But actually, when we get it wrong, it is devastating for the patients and the people around them. So quality assurance is about taking every opportunity to make sure that the quality of healthcare is right, take opportunities to see when it's not going right and see what we can do to address it and picking up on that. So what we're doing is looking at the way in which we look at quality assurance for our providers and changing it slightly. So we don't just have one person work with each provider. We have somebody now who looks at work across the patch, does extra work, does deep dives to see where we've got hot spots or things we need to know more about. So we're changing the way we work. We also have a mechanism whereby a commissioner will lead on a provider. So what we're doing is working more closely with our neighbouring CCGs to make sure we get the same assurance from them as we do about the work that we carry out. Again, we've talked about GP alignment a couple of times tonight. It's something we're really proud of and will really improve patient care. And going back to this upskilling of care home staff, they're a really important part of our workforce. We need to give them the confidence to be able to care for people in the care homes and keep them there. End-of-life transformation. It is about record keeping. It's about having a record that works electronic and is transferable. And there is a piece of work to look at how we do that. And just the last bit then, there is an assumption that end of life is really about people who have cancer, and there's some really good pathways around cancer care. But of course, not all people at end of life do have cancer, and it's how we make sure that everyone has the same opportunities to die in the way they want, and that's non-malignant conditions as well.
And it threw up a number of issues about how to strengthen the new service and the new provider going forward, particularly around patient education and better signposting people that are perhaps new to the city or new to the NHS, actually recognising some of the new and emerging communities we have in the city to help better support people around navigating our very complex system. So I've already touched briefly on the LGBT work, and Derbyshire Friends are helping us put together an action plan on how we can much better support people in that community, and particularly recognising the housing needs work, recognise some particular challenges around mental health, so that's one of the priority areas in that plan. And the corporate team have been supporting the rest of the organisation around understanding what PPI is all about and the importance of it, and undertaking some training sessions with all of the staff across our organisation. PHBs, so personal health budgets, this came into force on the 1st of April of this year, so although it's more a forward look for this year, this, as I say, is a really new, quite exciting development where we're starting to work with individuals around their own healthcare and providing much more choice and control, enabling people to hold their own health budget. Working alongside local authority colleagues who have been doing this sort of thing for quite some time, and it's really helping us think through how we can better support people at an individual level. And there was a campaign with the medicines management team that was very much centred, I think, around the Normanton area, where again the team identified groups of patients that needed better support around their medicines management, and there was a very particular piece of involvement and engagement that the team ran in Normanton.
Gathered by now that patient and public involvement is an absolute thread running through everybody's work, and it's really, really important. So, one of the things that we really need to do as a CCG is to understand our communities, particularly those that have health inequalities. So by working with public health, we're hoping to identify those and support the work being done, and particularly where there's the greatest need and the greatest health inequalities. The second one is about, Helen's just explained about personal health budgets. It's really exciting to see that work growing and to giving people the opportunity to have control and to think about different ways of making themselves better and keeping well by having more control. So that work will continue and we're learning a lot as we go along. The next one is about working with key partners to build community resilience. In order to have people that are receiving care closer to home and staying in their own home and thinking about self-care and self-management of their care, we need to have resilient communities. And one of the ways that we can do that is by working with the voluntary sector. They're best placed to know their own small communities, as Pam's already said in the VSPA presentation. But there are lots of other ways that the CCG can engage with the voluntary sector, and that's an important ongoing piece of work. Finally, reviewing and developing our PPI structures. For instance, the health panel was started when PCTs were in existence. And we're now in the process of looking at all those structures that we've got, the patient participation groups and the health panel, and making them fit for purpose. Most importantly, we're trying to make sure that the people that are involved in those groups actually get what they need from it and feel that they're making a positive contribution to the work of the CCG.
Just in terms of what the change was from 13-14, we had 2.5% increase, which was relatively good compared to other departments, government departments. We had an increase of 2.5%, and we invested all of that into services, healthcare services. Our running costs went up, but they were within our, we have an allowance each year, which is about £25 per head of population. That allowance did not go up between 13-14 and 14-15, and the growth there is really just the growth in year, which reflected us establishing ourselves as an organisation post year one. That's just a slide of all the targets that we have to meet. The couple at the bottom I'll just mention is the Better Payments Code of Practice. So the finance team worked really hard to make sure we pay all our bills promptly within 30 days to support local suppliers and make sure that their cash flow is okay. It's one way. We try and find external measures like that to measure ourselves and our efficiency, and that's just one way we do it, and close to 100%, which is not bad. And also we achieved our productivity target of 2.7%. Was difficult. We didn't achieve all of it in the way we planned to do at the beginning of the year, but it's important that we keep trying to improve efficiency of services year on year, and that's a target that gets more and more difficult each year.